Let's talk about gestational hypertension and preeclampsia. What the cause of right upper quadrant pain, periportal and focal parenchymal necrosis, hepatic cell edema, and Gleason's capsule distension. Risk factors for preeclampsia, nulliparity, multifetal gestation, prior preeclampsia, chronic hypertension, gestational diabetes, thrombophilias, SLE, BMI greater than 30, APS, AMA, kidney disease, IVF, obstructive sleep apnea. If you have hypertension less than 20 weeks, you have to think about other causes such as thrombocytopenic purpura, hemolytic uremic syndrome, motor pregnancy, renal disease, autoimmune disease. Severe features. What are the severe features? Thrombocytopenia, elevated liver enzyme 2 times the normal, creatinine greater than 1.1, pulmonary edema, new onset headache, not responsive to treatment. Gestational hypertension is elevated BP 140/90, greater than 4 hours apart. HELP syndrome, usually you have LDH greater than 600 IU per liter. Elevated liver enzyme, usually AST is greater than ALT. 30% can happen in postpartum. Right upper quadrant pain and nausea, vomiting. Eclampsia, it can lead to maternal death, maternal hypoxia, trauma, aspiration pneumonia. Press syndrome, loss of white matter with impaired memory or cognitive function. Usually they are transient. Usually you have loss of vision, altered sensorium. On MRI, you see presence of vasogenic edema and hypertensities in the posterior aspect of the brain. You also can have something called reversible cerebral vasoconstriction syndrome. You get thunderclap headaches and focal neurological deficits. Pathophysiology, chronic uteroplacental ischemia, immune maladaptation, very low density lipoprotein toxicity, genetic imprinting, increased trophoblast apoptosis, exaggerated maternal inflammatory response to deported trophoblast, imbalance of angiogenic factors, worsening renal sodium and water retention, transient oliguria due to 25% reduction in GFR, imbalance in prostaglandin and thromboxane A2. Prevention, can do calcium supplements if low calcium intake. ESA because it can inhibit the thromboxane A2, significantly reduce reduction in severe preeclampsia and growth restriction. We should start around 12 to 16 weeks, but you can start up to 28 weeks. If you have one of these are called major risk factors. Number 1 is history of preeclampsia. Number 2 is twins. Number 3 is history of chronic hypertension. Number 4, diabetes, type 1 or type 2. Number 5, renal disease. Number 6, autoimmune disease. If you have 2 of the following, you can also start. Number 1, first baby. Number 2, obesity. Number 3, family history of preeclampsia. Number 5, African or low socioeconomic status. That's number 4. Number 5, AMA. Number 6, IVF. Number 7, patient is low birth weight or previous adverse pregnancy outcome, or 10 years interval from last pregnancy, basically nulliparity. Delivery versus expectant management. Continue monitor until 37 weeks if no severe features. Weekly NST, serial ultrasound every 4 weeks. Normal fluids, that's weekly assessed, and weekly lab tests. Proteinuria expected to increase but do not affect management. FGR in the setting of normal fetal parameters, normal fluids, normal Dopplers, and NST can continue to be watched. Severe features deliver after 34 weeks. What are the severe features? 160 over 110. Make sure that cuff is 1.5 times the circumference of the upper arm. Patients should be sitting in upright position for 10 minutes or more. Should not have smoked or caffeine for 30 minutes. Persistent headache, epigastric pain, or right upper quadrant pain. Visual disturbance, HELP syndrome, creatinine 1.1 or 2 times the baseline. Seizure prophylaxis, magnesium. Contraindications for magnesium, myasthenia gravis. With these patients, we should try to use methyldopa or hydralazine for blood pressure control. Beta blocker or calcium channel blocker should be avoided if possible. For seizure prophylaxis, we use Keppra or Depakote. Other contraindications for magnesium, hypocalcemia, renal failure. These patients should still receive standard loading dose, and if their creatinine is between 1 to 1.5, you can do 1 gram per hour maintenance dose. If their creatinine is greater than 2.5, no maintenance dose. Other contraindication, cardiac ischemia, heart attack, myocarditis. You can continue to give magnesium during C-section and continue for another 24 hours after delivery. If no IV access, we can do IM, 10 gram loading dose with 10 gram loading dose and 5 gram every 4 hours, mixed with 1 ml of xylocaine 2% for pain. Deep tendon reflex loss is at magnesium level of 9 milligrams per deciliter. Respiratory depression is at 12. Cardiac arrest is at 30. Level should be done every 2 hours if MAC level is greater than 9.6, and MAC should be stopped. Level should be checked if renal insufficiency 1.1 plus every 4 hours. If creatinine is greater than 1.1, we should check the level every 4 hours. Emergency reversal with calcium gluconate, 10% solution, 10 ml, over 3 minutes along with furosemide IV for renal secretion. Half-life is 5 hours. So the antidote is calcium gluconate. Do 30 ml of 10% solution, 3 grams IV over 5 minutes, and cardiac arrest or severe cardiac toxicity related to hypermagnesemia. Magnesemia. Less severe cardiorespiratory compromise. We can give 1 gram starting dose. We'll continue to use furosemide to accelerate urinary excretion of MAC. Antihypertensives, labetalol, IV max dose is 300. Avoid an asthma, heart block, or bradycardia. The onset is 1 to 2 minutes. Hydralazine IV max is 20 milligram. It can lead to hypotension, headaches, or poor NST. Onset is 10 to 20 minutes. Nifedipine max is 180 PO. Onset is 5 to 10 minutes. Anesthesia, neuroxyl anesthetics is contraindicated if platelets is less than 70K. Postpartum NSAIDs decreases prostaglandins, leads to lack of vasodilation and sodium retention. For eclampsia, MAC IM or IV is superior to phenytoin or diazepam. However, if MAC can be used, you can use IV clonazepam 1 milligram or diazepam 10 milligram for sedation. Eclampsia should be delivered. If you have eclampsia, patients should be delivered in a timely manner. If less than 30 weeks, induction of labor is likely to fail. If seizure continue after the MAC, sodium amylbarbital 250 milligrams IV in 3 minutes, phenytoin 1,250 milligrams IV. Sodium amylbarbital. Clonazepam and diazepam. HELP syndrome, AST greater than 2,000, LDH greater than 3,000, suggests high morbidity risk. Low platelet usually occurs 23 hours postpartum. Increased risk for pulmonary edema, ARDS, renal failure, higher cardiovascular risk later in life, 2 times rate of cardiovascular disease and 5 times risk of hypertension.